I am going to, because we have a distance learning, so we record it, but I am very pleased that we have Professor David Ndetei and Victoria Matus, yeah, sorry, with us here. They come from Kenya, and I have told you about it in my mail. They both have been highly involved in work relating mental health in Kenya and elsewhere, and I think it was a fantastic opportunity to have you come and share with us your thoughts. So most welcome, both of you.
Thank you.
And please, if you would like to address, I'm going to sit there.
Yes, and I would like to control the movement of my slides.
Okay.
Yeah.
I can do that.
I can do it now. Can I sit up there? Okay.
So you can stand here.
Stand there.
Would you like
Okay, fine.
I think it's...
Yeah.
Thank you.
Do you want to control for me?
Okay, so you let me know when
You can sit over there.
Ooh. Should I have? He wants me to.
Fine. Before we go to the next one, let me say that we are very privileged to be in this country, beautiful country. We've been seeing a lot, beautiful people, and it may just interest you to know that there is an instrument, a tool that was developed in this country, and we tried in Kenya, and as a result of that, we developed this relationship, and we are here. We are very, very happy. So I thought I would share with you, if you just go back, I'll share with you our experience on duty collaboration for mental health research and services. And our focus is on community level. And there are very many reasons why we focus on community level rather than urban areas. And I'll tell you these reasons as we go along. We have very many hats, but these are some of the things that I do. But let's move to the next one. And may I with you. Now, there are a few things that we know for sure that there is a significant treatment gap in Kenya in spite of similar, and I want to emphasize similar patterns of mental disorders as found in high-income countries like your country. So the epidemiological patterns are the same, but then that's where we part ways, and I'll tell you how we part ways. There is poor and limited allocation of financial resources for mental health by the government. Less than 0.01% of the national health budget goes to the community. And let me also emphasize that 0.01% should be seen in the total context of the health budget, which is about 4%, and 0.01% is the one that goes to mental health. So basically, what that means is that most of the budget goes just to supporting staff who are working in the big psychiatric hospital. We have other issues like widespread violation or the rise of people with mental illness. Move on. There are high levels of psychotrauma as a result of very many things: gender-based violence, sporadic politically instigated violence. There is high influx of refugees and internally displaced persons, and Kenya has been in the news because of our relationship with the Somalia, which is just next door, and there is an open border, so they just come over to the country, and then Southern Sudan, there are also issues there. The human resources in mental health are totally inadequate. We have a psychiatric population ratio of 1, it should be 4. 4.1 into something like 450,000 population. So for every one country, for every psychiatry, we have about close to 500,000 people. As opposed to here, you have one psychiatrist for about 5,500. And this is also compounded by, and that most of these psychiatrists are only in urban areas, and most of the people live out there in the community. As in many parts of the world, there is widespread stigmatization and social exclusion of people with mental illness. In spite of all of these things, I think there are great opportunities where we can actually improve mental health. What we are saying is that there is no way we can hope to have the kind of psychiatric population ratio that you have here. And I remember a colleague of mine, we were attending a meeting somewhere, and he was asked how long it would take to achieve what you people in the high-income countries have in terms of human resources and mental health. And he said he didn't know, it was for a long time, but if he was put against the wall and he had to give an answer, then you say maybe 1,000 years. We are not going to wait for 1,000 years for us to be able to do something. So we must do something with the resources that we have. So there are opportunity for mobilization of resources for mental health, both in and out of the country, to minimize the treatment gap in the following areas, which I'm going to list for you. And the treatment gap is something between the region of 80 to 90%. In fact, at Kenyatta National Hospital, we found that patients, Kenyatta National Hospital is a national referral and teaching hospital where all the specializations operate, and where I also trained when I was a medical student. And we found that people with the depression, or if you took 100 people with the depression identified by well understood instruments such as the BEC, only 4% of them would be recognized by the physician and surgeons. So you can see even at that high level, the treatment gap is very, very high. So as we do all of these things, there is need for provision of evidence-informed intervention. Whatever we do, in spite of the poor resources that we have, opportunity that we can still do good research and find interventions that are homemade, that are informed by science, so that we don't do things that have no scientific basis. There is need for increased awareness and literacy in mental health to minimize stigma. That should not cost a lot, because you can use radio, you can use community health workers. I'll discuss these things with you as we go along, and tell them about mental illness. And in fact, we have made some good success in some of the work that she has been doing. And we have shown that by just going to the community and educating them about mental illness, how it presents, that there is no need for them to be stigmatized. People are coming forward for interventions. There is also, in my view, the importance of increased awareness of the rise of people with mental illness, their legal capacity in terms of ability to make informed decisions and act on them, and improving their social inclusion and economic participation. All these people are excluded, and we think that we can help them, in spite of their mental illness, to be involved in economic activities. And we have ample evidence that this is beginning to happen. And I think by doing this, we break the vicious circle of mental illness and poverty. Now, as we do all of these things, it's very important, as I said a little bit earlier on, that we are guided by the evidence. And our practices must be guided by certain principles. And I'll summarize these, four of these, and I'll explain a little bit what I mean about them. They must be affordable, that is within the prevailing economic status of the majority of the people. There is no point prescribing interventions and the people cannot afford them. Especially in a situation where less than about 65%, 60 to 70% of the people live on less than $1 a day. And therefore, you really cannot expect those people to afford some of those services. Although although we have succeeded in one of our study areas to get the government to fund everything. That's one. We have 47 county governments, and in one county government where we work, that's not an issue now because the government is funding everything. So it must be affordable. It must be appropriate, that is, must be effective, evidence-based, and context appropriate. Because the context vary greatly from country to country, and leave alone that within one country they can vary greatly, even within one country or within one big locality. So for every community that you are dealing with, you must make sure that you take the context into account. And these services must be available, are present on demand, and the people can make an informed choice on whether to take them or not. We don't want to force people to take these services if they do not want them. Are present on demand, I think, let me just explain this, that if you have a service that is only available 200 miles away, and you just can't say there's a problem, somebody has a mental illness and you have to travel 200 or 300 miles to access the service. So they must be, to the extent possible, provided at the point of first contact. And the first of contact varies remarkably with the kind of resources that are available. And I think that also goes with number 4, located within physical reach of communities and individuals. Now, how can we achieve all of this when we have only 90 psychiatrists for a population of 500, for about 45,000 people? What can we do? Are we going to emulate what is happening in the West? Can we ever catch up with high-income countries' human resources and financial resources for mental health? And the most unlikely, from my view, I'm not going to say 1,000 years, but it's unlikely for many generations to come. Yet, as I said a little bit earlier on, the epidemiological patterns are the same. Can we afford to wait? I think you would agree with me. No, good mental health is a human right to be enjoyed now and not tomorrow. So how are we going to do that, given the limitation that we have? And I think the best thing, and this is what we have been doing, is that we must be innovative. We must identify, sit down, and do a proper analysis of the resources that we have, and mobilize them. And I can tell you, by doing that, we have just discovered we are extremely rich in human resources. Only that we did not recognize those human resources in the context in which they occur. So achieving the 4 A's in the professional mental health service is a realistic goal, which can be achieved through innovation and involvement of all relevant stakeholders, from the community level to the global arena, in mutually beneficial partnerships for knowledge exchange and support. Now, what are some of these resources that we have? At the community level, stakeholders can be looked in very many ways. The family unit. The family is a very important stakeholder, and we can get them involved, especially if they have a person with mental illness. The consumers of health services themselves, the individuals with mental illness, they have a say. Don't assume that just because somebody has got a severe mental illness like schizophrenia or maybe a bipolar disorder or whatever kind of disorder that you have, don't assume that they don't have an opinion. They have their own opinions. And we have moved away from just dealing with individuals with the mental illnesses to working with the organization that consists of people who are consumers of mental health services with unbelievable resources, like they are part of the process. They are very important. There is what we call the formal healthcare system and the informal healthcare system. I will explain this a little bit later on. Can we move on? The formal healthcare system can is based at following the institutions and using different individuals, like healthcare, local health centers, and the health system in Kenya, the so-called formal, or the one which is modeled after Western system, has got little dispensaries which are actually at the village level, manned by a nurse or somebody who has a training, finished high school and received some training. And these are the people at the local healthcare level who are doing most of the work on HIV, on tuberculosis, on nutrition. In fact, in many ways, they are the backbone of the other services. If they have been doing very well and they have been very successful with complicated conditions like tuberculosis, HIV, nutrition, hypertension, diabetes, and so on, why is that we cannot involve them in mental health? Of course, there are other people who are very highly qualified, psychiatrists. I said there are very few of them. Counseling, the clinical psychologists, we have one here. We have nurses, psychiatrists, social workers, community health workers, and extension health workers. These are the people who belong to the so-called formal healthcare system. In Kenya, community health workers, although once considered lay health workers, have now been integrated into the formal health system and receives training from the Ministry of Education to act as liaisons between the community and the formal health system. They are able to reach the individuals and family in their homes. They actually know the people, their family units, and they know who lives there. And they know the families by names. They know who is a responsible parent. They know who the child who is having problem. So they are able to reach individuals, families, to provide psychoeducation, and the psychoeducation can be very, very powerful. It provides information or immunization, monitor compliance with treatment, make referrals to the local health center. I've already alluded to that. The informal sector is there, but is also, until recently, we didn't know how to use them. And they are very, very powerful. Faith healers from the level and dispensary to hospitals. These faith healers, if you want, call them the clergy, and they are everywhere. In fact, there is an excess of them. And these are the people who get consulted by people with mental illness and also with other conditions. But mental illness, which they may attribute to evil spirits or whatever, but nevertheless, they see these patients with mental illness. Is it possible for us to enter into dialogue with them and tell them that if you see people with presenting like this, let's talk about depression. If you see a person presenting like this, he is suffering from a medical condition we call depression. We don't want to challenge them on their explanatory model. They have their own explanatory model. But we can also tell them there's also another explanatory model. That these are conditions that have maybe social problems, they can be treated, and if they can't treat them, they can refer, and we tell them that you can treat them through things that are not very difficult to do, and in any case, they have been doing this for a long, long time. And there is wonderful, wonderful evidence from history where people, faith healers, have been doing very good job. Traditional healers, these are the traditional doctors who run into the I've just come from your museum, and Inga, who made it possible for us to come here, we looked at her genealogy and 66. From 17 something, okay, a long time ago. She's a sixth. One time, when I just come from training UK at the Institute of Psychiatry, I realized that I was dealing with patients who were seeing a traditional healer. And they spoke very highly of this person. So I went to see this traditional healer, and he invited me to see what he was doing. and he was treating people with sexual disorders, and they allowed me to sit in. And this man was prescribing Masters and Johnson's technique. Some of you will know about that technique developed in the United States very recently, actually, because we are talking about 1950s, very recent. And I asked him whether he knew Master Johnson. He didn't know what I was talking about. He didn't speak English. He only spoke the native language. And I asked him, how did you know about this? He said, my father told me, and he could remember all those people. I was told by my father, he named the father. My father was told by the grandfather, and he named the name of it. And he went on, and believe me or not, he went to 10 generations backwards. I just couldn't believe it. And now it's when I saw him as the 6th generation, now I'm beginning to realize that these things had been going on even before we were the first settlers in this country. So these people do good jobs. There's a story told about somebody, I think it was 1929 it was, a Nigerian who traveled to UK to treat a person who had gone psychotic, a Nigerian there. And he went with extras of a plant called Rawafi, which contained recipe. And he treated the Nigerian, he became very well. Now, if we are talking about recipe and then psychotic, a drug with some antipsychotic effects, 1929, long before we heard about delay and Denica in 1952. Okay? Long before we now Salatin Bean, 1939, ECT, and things like that. So these people have something. In any case, they are very well consulted and they have very highly patronized. We can work with them. We can work with the expert patient. There are very many of them because there is no shortage of patients with mental illness. Local self-groups and the community-based organization, very important. Don't underestimate them. Local families who have patients with mental illness, and the community opinion leaders. These are very, very important in the community. These are the ear of the people, and they can say your opinion in favor or against proposed interventions. Don't ever underestimate. They are also the custodians of community values, and they can offer valuable advice on how best to approach and implement your ideas in the community. There's a story, and it's a real story, and I'll tell you several stories, but I'll tell you one. Not long time ago, the World Health Organization was trying to treat cholera in one of the communities, so they went and dug very beautiful toilets, pit latrines, and hoped people would go there with you, the pit latrines, and there will be no problem of cholera. So they went away feeling very good. Okay, they went back. There was no, the cholera was still going there, and they found the toilets as clean as they had left them. And it was because they did not take into account that certain communities have cultural values where people who are close cannot share one toilet. And they assumed that they would. So working the community opinion, they will tell you what will work. And the most important, they will tell you what will not work. It doesn't matter the science. They will tell you it will not work. So we can, at this level, structure can be engaged to include, we are doing that, they come in, support even kind from level administrators such as those in charge of health and educational services, finance, can go a long way in ensuring that whatever you are doing is very successful. We, scientists, must learn how to communicate with other people who are not scientists. Let's not go bragging about the scientific merit of the work we have done, the people used and things like that. They may not understand that. So we need to engage with the government right from the beginning so that we tell them what we are doing. And we work also with the service providers and together as a team. And in fact, for us, we don't mind engaging them in such a way that at the end of the day, they don't say these ideas that belong to Dr. Mtizo or belong to Ndetei. They have their own ideas and they own it. That way, we may be able to shorten the distance that in terms of time from new inventions to practice, which has been said takes about 17 years and only a small percentage get there. So if we engage all of this, we will get there very quickly. We need to work with the civil society, human rights and other organizations. They can give voice to the issues and are useful in mobilized communities and resources towards the achievement of common goal. Organization and regional bodies operating in the health sector, such as the East and Central Southern Healthy Committee, which we have in Kenya. We have government organization working at that level. We can engage them. In other words, what I'm trying to say is that if you look around, there are so many resources. Low-income countries, the similar socioeconomic, political, and cultural context can share experiences and replicate successful models with the minimal cost. For example, like Kenya, India, and Zambia, and Nigeria, and some of the other countries that we are working with. And then, of course, working with you, collaborating between high and low-income countries is a source of exchange in crucial expertise, which is often lacking in low and middle-income countries. For example, I think people now are moving into areas of biomarkers and other markers of indicators of mental illness. We may not have the expertise in terms of doing genetic studies, but I'm sure we can work with you. The opportunities are there, and you have that expertise. So please, even living here, I want you to know there's so much that you can contribute to what is happening in the low and middle-income countries like Kenya. It is exactly for the purpose of using this multi-track approach to harness the resources for mental health is that we formed the African Mental Health Foundation. I'm a professor of psychiatry at the University of Nairobi. I spent all my time doing research, and I was just churning papers and throwing them backwards. And what was I doing? Getting promotions, getting opportunities, maybe to travel, and things like that, until I realized I was actually very selfish. I was just doing that for myself. What was the benefit? What was the benefit of this work that I was doing? So when I did an audit, and I have trained most of the psychiatrists in Kenya, when I did an audit of what we had achieved, I was very disappointed. Yes, we are doing this, we are doing very well compared with other African countries. We have one psychiatrist for over 1 million people, compared with Ethiopia with one psychiatrist for almost 2 million people, Nigeria with one psychiatrist for more than 1 million people, our neighbors, Uganda, Tanzania, one psychiatrist for more than 1 million people, some of them 2 million people. But when I did the analysis, I realized these guys were only in urban areas where the majority live. The people out there had no chance ever of getting to the health side. So we decided we needed to change the model. Climbing down from high water tower, coming down to the people and saying, hey guys, what can we do? Okay, nothing that's not really academic. Now, let's move on very quickly. That's our logo, and these are some of the things that we do. You can distribute this presentation. You can make it available to everybody.
Yes, it is already available.
You can read for yourself. Let's move on. These are things that you can move on. You can see. These are some of the areas that you see. We have community mental health intervention for non-communicable diseases. We've been doing work on the diabetes, cancer, hypertension. We are continuing. We now begin to focus on mother-child health. Move on. Early child development, school mental health, including substance abuse. In fact, this one we are working with the Ministry of Education, and what surprised us very, very much, we just couldn't believe it. that by using simple techniques like life skills, and you teach children how to handle issues in life and things like that, then they improved. And we were able to show it was not just by chance that they improved. We are not going into the details. By teaching the parents that these children with mental illness can present like this, their awareness increase, and so on. Suicide are becoming a very important issue. Cause-effective and biological and psychosocial intervention for the various types of mental disorders, and so on. Part one I will skip. Now, let me just show you a few things that I think are very important. These are some of the people that we work with. You probably recognize that guy over there. You recognize this person here. This is the Minister for Health in one of the counties, and we are working with him. And I can tell you, because of working with them, in that particular county, we can actually go away because the service is available and they paid. They are for free. Of course, they don't have the resources, the one that you have, but somehow we have managed to move on. And of course, you work with people. This lady is from Canada. Move on. And I think this lady is, who is this? This is Valerie from University of Vermont in USA, talking about training people on research assistance in the field. This took place in the field. Hey, what is this? Where were you? Where were we, Victoria?
Right in the rural areas with traditional healers.
Yeah, right in the rural area with the traditional healers. These beautiful women we are seeing wearing our t-shirts, traditional healers, and we are telling them how to recognize mental illness. And they make better referrals. They make better referrals than doctors. Okay, can we move on? Dealing with the schools. This is a rural school, and these children, we educate them on life skills, which is developed by Ministry of Education concerning World Health Organization. So it's using instruments that have been validated. Move on. And recently, we had a very important visitor. This guy is Peter Singer. He's the CEO of Grand Challenges Canada. They have funded us quite a lot. And in this place, we were dealing with people with mental illness. Okay? These are people with mental illness. These are guys you are seeing are people who have had mental illness. And we set up businesses for them. And they are doing very well. And the stigma is going down very quickly, or fairly fast. Move on. Now, who are these guys? Again, these are traditional healers. Is that correct, Victoria?
Some of them that in our trauma clinic.
Yeah, in our trauma clinic. This is in Kibera. And these again are women who had been subjected to trauma, PTSD, and we started businesses for them, and they are doing very well. Yeah, move on. And I'm very proud of this. You probably recognize me, but because of our policy of teaching Makwen the importance of mental health, they have for the first time sponsored a student, fully paid for, to come and train as a psychiatrist. And as we are talking now, he is training in our department. Move on. And this is another team of, this is a part of our team. These are our building, African Mental Health Foundation, and this, in fact, basically these are our staff. All of these are our staff, some of our staff. And we had visitors, I think these had come from...
These guys, these ladies.
Yeah, they had come from
Maastricht.
From Maastricht University here in Holland to come and work with us. But these are some of our staff, and all these guys are doing nothing else but either collecting data or supporting people who are doing research. And that makes my life very easy because I can travel and research will continue. Okay, let's not go into that. And let's not go into that. You probably know about these big document, the Mental Health Action Plan, 2013. We are trying to follow that to the letter, and we're seeing very many examples. And let's move on. And move on because I want to complete. These are some of the projects that we are trying to do. Move on. We are finding very good results. Move on. And to move on towards the end, these are some of the things that we are. So, let's go back. What do we hope for? It is a hope in the very near future. And remember, the WHO Action Plan is 2013 to 2020. 2020 is only 3 years from now, right? It is a hope that in the very near future, and working together with the partners in Kenya and outside Kenya, we will be able to achieve provision of mental health services down to the very least and the very last in our social structure that meet all those conditions. At the moment, we have achieved that in one county. And the governor has said that he will go and talk to the other 46 governors and tell them what he's doing, what is happening in that county. In fact, it was national news. And then after that, they will take it to the president and talk to the president about this. So this is our calling and the very existence of the foundation. And our activities are revolved around that calling. Yeah, because on demand, we just branding African Mental Health Foundation. I just received a word this morning that our chairman of the board of the board has approved this one from African Mental Health Research and Training Foundation. Has been approved now. Just waiting to do all the things. All that is basically to align it to what we already do and bring out that research and training and foundation, because basically we are charity and we want to retain that element. We are not interested in making money. Whatever money we get, we plow it back to the activities. Shall we move on? I think that one can be done. There's still lots of things to be done. Move on. Now, I've come all the way from East Africa to see your beautiful country, meet your beautiful people. I've heard a lot about them and about the wonderful work you are doing, and seek opportunities for collaboration with you, you develop a solution, and they provide opportunities for research for your students and those who want to work over there, and maybe some of our students, but we still can collaborate in very many opportunities. That's why here, and together we can make a difference. And I just want to give you this example. In Nairobi, we are very close to the national park. In fact, sometime, if you are lucky in quotes, you can meet a lion on the street. Yeah, please don't think it's a big dog. It's dangerous to run away. But this is a cheetah, one of the fastest animals in the world, and this is the hyena. This hyena was trying to interfere with the kill of this that had made, so he had to be chased away. So a lone hyena the cheetah does not eat hyena, but it will be killed if it tries to interfere. Now, if you look at this, this is a leopard, and a monkey, a lord monkey, in the presence of the elephant, in fact, is a delicacy. One of the things I've learned here is lamb. Is a delicacy. And eating sheep head is also a delicacy. We saw it last night. And of course, fish and things like that. So this is fish or lamb to this. But you see, when these monkeys go together, they put this elephant into flight. I am not saying we are monkeys. But what I'm saying is that if all of us can get together, we can put this animal mental illness and the costs and the devastation it causes to families, we can put it on flight. Then Just want to say thank you for your attention.
Professor Davis, thank you very much for this panorama on your work. Any questions?
Yes, I'm Prof David. I'm an associate professor of psychiatric nursing at the University of Iceland. I'm wondering, are you already in some collaboration with Icelanders? Or?
Very good question. I met, you have developed an instrument there for substance abuse. I met somebody in Lisbon 4 or 5 years back. They gave us an instrument. We tried it. We found that it worked. We are trying to develop collaboration. Yes, we are in the process of trying to negotiate collaboration.
Rannsóknir og greining for those who are
we are in the process of trying to develop collaborations, and if you have 10 ideas, that's why we are here. We want to talk. We are, right now, we just come from London, and one of the people really I want to promote, which are very, very useful and very relevant to us. I want nurses, and I'm talking about the Kenyan context, to get involved. Involved in a very active way, not in a passive way. And we are planning to train them, if we succeed, in them taking the decision and the initiatives to develop their own research projects and implement those research projects, and we will support them so that they feel they are active participants of the whole process, not just passive participants. We are planning to do that. It's a thought that we already have in mind, and we are more than happy to work with the people from this country.
Any question? Engilbert?
Yeah, I'm just wondering, I mean, you have this network of healers in your country, which is something that goes, I guess, generations back, even thousands of years. So you have like a network in place. But how motivated are they to learn about mental illness? Because, I mean, throughout the centuries, mental illness has been, I mean, somebody is doing voodoo to you on the west coast of Africa, at least. There are different explanatory models. So
Yes.
how open are they to becoming a part of a health network for mental health?
Extremely open.
Yeah.
And we found that through dialogue with them. When I didn't include that photograph, but the first time we tried to get the traditional healers and the people working in the health centers to talk. It was extremely difficult. I mean, we brought them and they didn't talk. I mean, they just looked at each other, like saying, who do you think you are? And they said, no, that kind of, that body language. And every person gave different reasons for not wanting to talk to the other. The nurses and the clinical officers and the doctors said, how can we be associated with these guys? Many of them never went to school. I went to the university. I did my medical degree. I did nursing degree or nursing work, and you are telling me to be associated with these guys? No way. Okay? And the traditional healers tell us, well, you know, whether they like it or not, and we know it's true, that they are seeing the patient, they are patronized. Whether they like it or not, we have the patients. They can give their university degrees, or we keep the patients. And then they are patronized by the patients. So it is a fact that we are fighting over the same clients. We are not saying what the traditional healers do is always correct. They have their own explanatory model to do witchcraft or what, even for simple things like depression. Okay? And they don't know that they are dealing with depression. But we were able to show that if you presented case of depression, a person who is depressed, he says like this, these are the symptoms which are contextualized. They will tell you, yes, we see too many of those patients who present like that. In fact, we even have a time for it. Okay? He said, okay, fine, we are not attacking the way you explain it, but there is also this other explanatory model. These are people with the depression, a condition we call depression, which you call the name that they gave us, and they can be treated in very simple ways. Listen to them. They can have family problems, social problems. You can prescribe single psychosocial intervention, and we know that this single psychosocial intervention works. But then there are some of them who need the medication. Can you now refer those patients to those people with this condition who need treatment if you can't manage them? And you see what we have discovered, because of course this was after long negotiation with the people in the health centers in the hospital setting, but they started referring these patients to these people treated them, they improved, and the traditional healers actually became even more popular, because the traditional healers are making discoveries, as it were, making referrals, and patients are improving. So there's a limitation as to what they can do. There are terrible things that they do. But can we talk so that we tell them, don't do that. We emphasize on the positive rather than on the negative, and we tell them, play down on this, is not just the help, but if you work like this, it's going to help. But you know, it's very easy for us in training the Western model to assume that we also don't do terrible things. We sometimes do terrible things to patients. So before we can see the speck in other people's eyes, let us remove the log in our own eyes. I think we found that by talking and establishing dialogue. In fact, we are published how we want to establish dialogue. And then the choice is very simple. These people, we know that they have depression, or they are suffering from different types of psychiatric condition, and they make it their own decisions to go to those people. Surely, for the sake of those people, they are Kenyans, they are citizens of the country. For the sake of those people, why don't we have dialogue with them and tell them how they can improve the services? It seems to be working.
This is a common dilemma in healthcare. It's so frequent, but very short quarrel, because the time is passing, or if you have any, because this is an opportunity to ask people who are at work.
Thank you. I have one or two questions.
Sure.
First is, does the professor is a traditional healer?
Sorry?
Professor, you are a traditional healer, because in our countries is to talk with traditional, it's not easy. If you are not traditional, they don't respect you.
Okay, fine.
Yeah. And
let me answer your question.
yeah.
I'm a psychiatrist,
Yeah.
trained in one of the best Institute of Psychiatry, mostly hospital, one of the top in the world.
Yeah.
Yes.
Very good.
Yes.
And second, do you have collaboration with West Africa countries? Because I think it's really important.
I've just trained 2 psychiatrists from Liberia, from Sierra Leone,
Sierra Leone. Yeah.
and I've just come from Nigeria, and we are thinking of working on collaborations.
Only English countries, no French and what?
Well, I think that's a big dilemma. We are basically divided into English-speaking, French-speaking, Portuguese-speaking. There are very few countries that speak Portuguese in Mozambique, Angola, and
Guinea-Bissau.
Yeah. The majority speak English. This has nothing to do with us. We are just one of those products of colonialism, and we have no choice in deciding who to colonize us. So I think it's time we started breaking those barriers.
Yes.
Yeah.
last question.
Sorry?
Is last question.
Sure.
How do you think can we capitalize the knowledge of traditional healers? If you know their family generation, they give center knowledge about families.
Yeah.
You know, if you take generation, you can have one generation, and now we are seeing some part, because last year in Guinea, during the Ebola disease, we have a lot of problem between traditional healers and medicine, and how to capitalize that knowledge.
I think my response to this is this. It is the people who make decisions where they want to go. And you cannot stop them. Even if you try to stop them, it doesn't work. They still go. Okay? But traditional healers may be doing terrible things. I'm not protecting them. They do terrible things. But they do terrible things because that's the best thing that they know. Okay? Not long time ago, in the last 100 years or so, people with schizophrenia used to be treated by being beaten or put in cold places or being put even insulin. Terrible things done by doctors. Okay, not long time ago. But what I'm saying is this. Is there a way of saying we have one common factor, and that is the patient. And we want to rescue that patient from those harmful practices of the traditional healer. Can we dialogue? There's dialogue. And for us, dialogue has worked. It has worked because we are referring patients to health centers. It has worked because many people say we are getting good results from the traditional ones. It has worked because we have a new explanatory model. It has worked because there are many psychosocial interventions for which definitely you don't need a psychiatrist or a highly qualified person. Interpersonal therapy, talking therapy. Surely you don't need to be a very highly qualified psychiatrist to do that. So that's all my
We have sitting in the venue, we have passed the time. You are most welcome to come and maybe talk to him after the class. But I would like to thank you, David, very much for giving us the time to come here in our motors class and discuss with you and share with you your experience. It was very stimulating and it was, I thank you very much. And Victoria to be here with him and taking care of the slides. And we are, so, thank you once again.
Very interesting. Yeah, we can just work together. Yeah. I would like to send my students to you. To broaden the worldview. I've been working on, I've been working in Africa for ICSC, Red Cross. Oh, okay. In psychosocial support to volunteers. I've been in Nigeria. Which part of Nigeria? Abuja. I've been back all over.
En ég verð að rjúka hins vegar tíma. Ég kom með bara tíma eftir að rjúka frá skrifstofu. Nú er ég bara að vinna bara áfram.
Gaman að því og svona ánægilegt að gefa þér tíma til
Nice to meet you again. Wish you the best of luck and good to see that you're wearing a sweater in a cold country. Okay.
Takk að kærlega.
I actually don't know.
So thank you so much. This was very good.
Yeah.
To be here. Now I have to stop the